our seminar series.
Thank you so much, Amanat. It's a real pleasure to be here. I'd like to acknowledge the traditional custodians of the land from which I'm presenting today, which is the Gadigal people of the Eora Nation. And I'd like to acknowledge elders past, present, and I'd like to extend special respect to any Aboriginal people who are listening to this presentation either now or who later download and watch this through the recording. I would also like to make a very special acknowledgement of my colleague, Dr. Florian Vogt. I'm presenting quite a lot of Florian's work here today. He did the quantitative aspect of this study. We will also speak a bit about the mixed methods thing. So I'm talking to you about the effectiveness of the COVIDSafe app in New South Wales. And probably a few of you, when you saw this topic, thought, oh, the COVIDSafe app, what happened to that? There was probably a time when quite a few of you downloaded it and maybe looked at it for a while, and I suspect that many of you in the time since 2020 may have got rid of that app from your phone for a number of different reasons, some of which we'll talk about in our presentation today. It's the notion of the COVIDSafe app has been largely replaced by QR code scanning, and of course where we are now in New South Wales, we're not really using that very often either. So initially, there was a lot of enthusiasm about this idea of digital technology that was going to be able to find contacts. You may remember the Prime Minister talked about this as something that was going to get us back to the football, which I have to admit was never my ambition, but it may have been some of yours. So what happened with the COVIDSafe app? You may have noticed that things went very, very quiet. And not to be too much of a spoiler, it was not as successful as it was planned to be. We were hired basically by New South Wales Health, a small team of researchers, to work with them to evaluate the app. So to look at it in the context of New South Wales over a particular period of time, which I'll show you. In this presentation today, I'm going to talk to you about how ineffective was the app, why wasn't it effective, and what can be learned from this particular experiment, and see whether this might be useful for other people who are interested, or other contexts in which they're thinking of introducing digital contact tracing apps. We do know that there are various smartphone systems that have a contact tracing function in many countries in different epidemiological contexts, and some of those have success. So the lack of success with the COVIDSafe app can't necessarily be generalised, because we'll talk about a number of the particular factors that were problematic in this app. So let me talk to you about smartphone-based proximity tracing. The way that that an app on your phone works to do contact tracing work is that smartphones exchange what are called handshakes or pings using Bluetooth signals. And the duration and frequency and strength of signals determines the contact between phones. And then there's rolling data storage on users' phones. And there are two different ways that this can happen. This can happen through a centralised design where there's a centralised database where the contact notification goes to public health staff with a particular secure database and can only be accessed by public health staff. And you can see on the left there are some particular countries that use that. There is also the decentralised design where there's no centralised data hub, but contacts get automatically contacted if there is a ping between phones. So that's a completely automated method and with no health authority involvement. Let's contrast that for a minute with how manual contact tracing works. In manual contact tracing, every newly diagnosed case is interviewed by public health staff. Their exposure history during their infectious period is taken, and there's a risk assessment done to identify high-risk contacts based on a standardised close contact definition. Those close contacts are then notified by public health authorities and asked to test and quarantine. Now, as you can imagine, this process is time-consuming, it's resource-intensive, and it can be quickly overwhelmed in high-incidence settings. And we saw that even in 2020 in Victoria when contact tracing authorities were finding it very, very hard to keep up with the level of infection that was happening. And so these are the reasons for which it seems like digital contact tracing is a good idea. And we have these two different models that we've outlined here, with Australia adopting the centralised database. The concept behind the centralised design is not that it will replace traditional contact tracing, but that it will be an adjunct to it. And the idea was that it would probably, well, the thought was that it was going to add value without adding work to the work of contact tracers. So, in the context of using the COVIDSafe app in Australia, public health staff ask all new cases about app use. And if they say yes, they get informed consent from the case. So when I say case, I mean the person who's been diagnosed as having COVID or SARS-CoV-2 infection. So if the person says yes, they are able to release the data from their phone onto a centralised database. And then a normal case interview still proceeds. In the meantime, the filtering algorithm on the phone, and that it's been downloaded into the database, applied to all handshake signals to approximate the national close contact definition. And then the app comes up with a suggested contact list. The third step there is the public health staff review the app suggested contacts on a secure web portal. They do a risk assessment and reconciliation of information from the case interview and venue attendance lists. And then they form the real close contact list. And the public health staff informs all real close contacts that they need to self-quarantine. And so the close contact definition in New South Wales in 2020 was face-to-face contact for at least 15 minutes over the course of 1 week during the case's infectious period, or presence in an enclosed space with an infectious case for at least 2 hours. And so this was approximated in the Bluetooth signal, supposedly. So the aim of our evaluation was to assess the contribution of the COVIDSafe app as an integrated tool within the contact tracing system to the COVID-19 response in New South Wales. So our objectives were to look at the effectiveness, which includes the sensitivity, the positive predictive value, additional close contact yield, and exposure events prevented. And we did this using a mixed methods design. We did an analysis of routine data, and for that we used the New South Wales Notifiable Conditions Information Management System, which gets abbreviated there on that slide to NSIMS. And we looked prospectively at data collection from app-using cases and their contacts. The study population that we were looking at was confirmed SARS-CoV-2 cases between May 4 and November 4 in 2020 who were registered in the contact system, who were above 12 years of age because there's not consent to use for people below 12 years of age, and whose infection was not acquired overseas. So we weren't looking at overseas acquired infections. In terms of the sensitivity, we were looking for the proportion of all close contacts identified by either conventional contact tracing or the app that were app suggested. With the positive predictive value, we were looking at the proportion of app suggested contacts assessed by public health staff to meet the close contact definition. That is, we were looking to see who the real close contacts were, and checking whether there was an additional yield of high risk contacts who were missed by conventional contact tracing, because that was the premise of the app, was that some high risk contacts might be missed in people's daily life, and that technology such as the digital tracing technology would be able to find those contacts. We're also looking at when the data were being looked at by the public health people, we were looking at whether app data were accessed by public health staff, the reason for not accessing app data, if that was the case, and the total number of contacts identified by the app during the case's infectious period, and the number of contacts identified by the app that were determined by public health staff to be real close contacts. So in this graph, you can see the period of time in which we were conducting the study. So between May 4 and 4 November 2020. As I've said, we were excluding overseas infections, and only the black and Yeah, so we're looking here right across that period there, and you can see the black and red bars are the cases that we are looking at. So these are the eligible cases. The kind of bluey grey ones are overseas acquired infections. So during that period of time, 619 cases were identified in New South Wales, and 22% of those, or 137, were using the app. And for these 619 people, there was an estimated 25,300 close contacts overall. So you can see the enormous amount of work that this is for contact tracing staff. Over 25,000 close contacts generated by only 619 cases. Now, there are some interesting demographic features to look at here. In terms of the cases who were using the app, we found that they were less likely to live in socioeconomically disadvantaged areas. So they were living in relatively affluent areas by postcode. They were more likely to be born in Australia. So we weren't getting Australians who were born overseas in as higher percentages. They were more likely to have acquired infection from a contact outside their household. And they had more close contacts than cases who were not using the app. And that's interesting because that suggests some kind of self-selection in terms of people's app use. People who were more likely to be in contact with the outside world, or perhaps a little less locked down, were using the app at a higher rate. So the big bar there with the 619, that's the total number of cases that we looked at who were using the app. The second bar there, that's the total number of cases overall in New South Wales in the period. Of those, 137 of them were using the app. However, data was only accessed for 92 of those. And so there are some reasons for public health staff not accessing the data. That can be because the case was in isolation during their entire infectious period. So if a person had already been identified as a close contact of somebody else and told to isolate, chances were that throughout, in some cases, in fact, this applied to 31 people, that they were in complete isolation. So the app didn't have to be checked on their phone because they weren't in contact with anybody. In some cases, there were technical issues that meant that the app couldn't be accessed. That happened for 5 cases. In 4 cases, there was loss to follow-up, and 3 people didn't actually give consent. So consent was very, very strictly adhered to in terms of the use of the COVIDSafe app. And so even if you had consented to it initially, when you were asked at the time, as a case, whether you consented, you asked again at the point that you were diagnosed, and you were able to say no if you preferred not to have the data accessed. And 3 people opted to do that. And so column 4 there shows you the cases who provided app data for this analysis, which was 32 people, which is 5% of the total. So this slide here shows the positive predictive value. 32 cases with at least 1 app-suggested contact had 205 app-suggested contacts, of which 79 were accessed by public health staff to meet the close contact definition. So out of those 205 that were shown as being close contacts, when they were actually interrogated by the public health staff, only 79 of those were found to actually really be close contacts according to the definition. The probability of an app-suggested contact to be actually a real close contact was thus 39%. So that's the positive predictive value. Examples of app-suggested contacts who did not meet the close contact definition included neighbours in apartment buildings, and so the app was picking up signals between walls, office workers in adjacent rooms, again, signal going between walls, guests in neighbouring restaurants, or people waiting in separate cars at COVID-19 drive-through testing clinics. So the app so in some ways you can see here that it was a blunt instrument. In some ways it was picking up contacts between people who were in a particular proximity, but it was unable to actually discern whether there was a real risk, because obviously if there is a wall in the midst of that proximity, there can actually be no risk. In terms of additional yield, these 79 close contacts originated from only 20 cases, very few from 619 overall. Importantly, remember there were 25,300 close contacts overall from these 619 cases during the study period, who were identified by contact tracing and the app combined. The app identified 79 out of 25,300, which is 0.3% of all close contacts in New South Wales during the study period. And further, of these 79, 62 of the 79 were also identified by conventional contact tracing. So the additional yield that the app actually gave us during this time period of 6 months was only 17 additional cases who hadn't also been picked up by contact tracing. So in terms of the sensitivity there, app using cases had a total of 1,073 close contacts identified either through conventional contact tracing or the app or both. And the sensitivity is estimated at 35 divided by 236, which is 15%. That's proportion of all close contacts that were identified by the app. Now, part of the research that I was involved with was the qualitative work. We interviewed public health contact tracers in 2 different phases. Initially, we interviewed 8 people who were contact tracers who were immersed in the system to talk to them about the expectations of the app. And then we interviewed another 6 contact tracers who were intimately involved in actually using data from the app into together with the contact tracing. So they were doing all of the app data for New South Wales. And what we were told was that, I'll read you this quote from participant 8. "We know it's missing people all the time because, you know, I can really only think of 2 occasions that we had to follow up so many contacts, and generally there's a few. And we know sometimes some of their contacts have the app because they tell us, my wife's got the app, but there's no pings. So we know that's not helping us." So overall, things that we found from the qualitative findings were that the app vastly underestimated contacts on iPhones. It also tended to overestimate contacts on Android phones. So that means that this supposedly carefully calibrated way of the app actually discerning the close contact definition that has been defined in the guidelines, it didn't actually work. It tended to, if you had an Android phone, it sometimes picked people that were far too far away to actually meet the close contact definition. And with iPhones, it often didn't pick up people, even if they were in the same house. There were also some basic logistical issues that were happening. As those of you who perhaps downloaded the app found, it tended to only work if it was on in the background and it drained batteries. We also found, which were great disincentives to people using the app. So people may have been quite enthusiastic about it initially, but they didn't use it. Then we have the issue with how well it actually counts close contacts. Another issue with the public perception of the app was that many people believed that the app actually had geolocation, which it didn't. Now, from the perspective of the contact tracers, they would have infinitely preferred it to have geolocation. It would have been much more useful for their process if it had had that, but it didn't have that. However, that many people in the general public believed that it did, and they were put off that for privacy reasons. They believed that that was going to infringe on their privacy. So in summary, there was low app use among cases, so only 22% of cases actually used the app. It had poor diagnostic performance with a positive predictive value of 39% and a sensitivity of only 15%, and a minimal additional contact yield of only 17 actual cases. In fact, of those 17 cases, none of those ended up actually causing an additional case. So no single public exposure event was prevented. As I've said, few people at risk of infection had downloaded the app because of, in some cases, privacy concerns. And the privacy concerns were heightened by the idea of a central database. And as I've said, many people believed that the central database was actually picking up geolocation, although that was not the case. In fact, the privacy settings were very, very strict. The privacy settings were so strict that if the public health staff were having to look at the list of names and numbers generated by app data, they weren't able to say to the case, they weren't able to actually triangulate between the two because they couldn't take data from one setting and directly ask a person the other. That meant they had to do all of the detective work piece by piece by piece, which added considerably to the work. The second dot point there about the failure to have large uptake was, as I've said, phone performance concerns, battery drainage. The Bluetooth was not designed to ping other phones, so low data availability for public health staff and low diagnostic performance. And so, in summary, many people at risk did not download the app, and that was one of the key issues there. So we have both the low uptake and we have functionality concerns, including the negative impact on phone performance. Arguably, the Bluetooth was not fit for purpose in terms of it having low positive predictive value and low sensitivity. As I've said, there were particular issues that were related to iPhones. And people actually had to have the step of having the app up and running in the background. So in terms of recommendations, what we get from this study is that you need to have effectiveness evaluation of apps that are designed to help particular populations in doing their routine work. We have argued work has recently been published in the Lancet Infectious Diseases, and we've argued there that it's really important to actually work with the end users. So if you are going to use a centralised model for a digital app, it's important to work with the end users, those being the contact tracers, to make sure that it is fit for purpose and that it's going to actually help with workflow rather than impede workflow, which was what we repeatedly heard in the interviews with contact tracing staff. The contact tracing staff had begun as being very, very enthusiastic about the possibility of what this technology could bring to their work practices. But then those who were involved in using it found that it really failed to meet their expectations. So this goes to show the importance of actually doing evaluation of these kinds of technologies, but actually running careful pilot tests and working with the workforce who is going to be using the technology to make sure that it is fit for purpose and that you get good value for money. So I will conclude there. It's clear that this digital contact tracing technology is no quick fix. And I'm very willing to take any questions that any participants might have.
Yes, any questions from the audience?
I have a question. I have two questions, actually.
Yeah,
sure.
Thank you, Bridget. You're an excellent presenter as always. I was just curious about, are there any plans for the future from New South Wales Health, like to maybe start doing some planning now? So if anything big happens again, they've got something ready to go.
That's a great question, Emily. As far as I know, not. I mean, I think that in the time that, from the time that we started that evaluation, QR codes came in and they were shown to be far more effective at a particular point in the epidemic, because for starters, they were mandatory. You know, you weren't. And so I guess that did kind of creep in the use of QR codes, but it's also basically stopped now.
Yeah.
So I think the feeling that we had from contact tracers was that they are still open to this idea of digital technology that can help, but this was not the technology. Contact tracers were also very keen on geolocation. They did repeatedly say that if there was actually geolocation included in that app, it would have been much, much more useful. And they explain, we have lots of examples of them talking through situations going, if we'd been able to see where these two people were, it would have cut an enormous amount of the work. But that had been decided at a higher level in terms of privacy, that geolocation would be highly problematic. One of the issues was the public didn't know that, so it was still off-putting to the public, even though it didn't happen.
Yeah, and so that was my second question. It's more a comment really about that, like the geolocation, because I guess I'm just curious about all these perceptions around privacy and people having concerns about being geolocated, but all the phone companies have everything, like all of our geolocated, like people already have that data. So do you think people just don't understand that people already have that data? Like, is it a conscious thing when people are saying we're asking for it, but they just don't realize that there are already these huge databases with all their information in them?
I am with you on that. I think that people don't recognise that data is being held somewhere, but perhaps people have particular concerns about the government having that information. I mean, when we think of some of the things that did happen in terms of people being found to have SARS-CoV-2 infection, I don't know if you remember, there was a security guard in Victoria whose basically all of his movements were published in the paper, and there were about five different opinion pieces with talking about, I think, how many different Bunnings he went to or how many different Kmarts. And so sometimes quite identifiable stuff. And there was this sort of sneering tone to it. And I guess for me, coming from the context of working in HIV, it's so important that people feel absolutely safe, that when their data goes somewhere, that it is treated just for the purpose that it is intended to. And so I wonder about the impacts of those kinds of things on people's feelings of security. But of course, it wasn't actually the government that was publishing where that security guard had been. That was, the media. But they were able to do that legally, and they had got that information somewhere.
Yeah. Oh, it's an interesting space.
Yeah. I got like a comment. It may not be a question. Like, I think like all these contact tracing apps, and then even the manual contact tracing, they all fail when the numbers are going high. So like the contact tracing and manual contact tracing works only in the initial period of the pandemic or epidemic wave.
That's a very good point. And it was something that we found in trying to make appointments with contact tracing staff, was that that the work, even during that period when there were only 619, you saw, there were over 25,000 contacts that were generated from that. And from my perspective, I made multiple appointments with people for interviews, and then suddenly it'd be, no one could do interviews. We are all contact. So there were these periods of intense work. People were working under enormous pressure, up and down. But during that period, when there were contacts, it was very, very much people had to, you had to have this vast concentration. But what this study shows us also is, if the sensitivity of the app were operating in the same way and it were decentralized, there were so many false close contacts. And imagine if all of those people had to, go into isolation. If it were just operating in a digital way, if it were going, directly, if you didn't actually have that centralization. So there are some big issues there to deal with. As you say, how can we expect teams of people to actually contact trace when you get an epidemic taking off?
Yeah, it's I don't think it's possible. Like, I can't think of it being possible when so many people are getting COVID, and then
But if it's going to happen just digitally, you need to be able to trust that what the device is telling you is true. And what we found in this app was, many times if that information had gone straight out to people would have been getting information that wasn't true, and they would have been being asked to, make very big sacrifices that actually weren't justified. So that would be really problematic as well. So you have to you need a system that has been calibrated to work really, really well in the epidemic context that you're talking about. And we're a way off that at this point, unfortunately.
Yeah, thank you. Is there any other questions from the audience?
If there's one other thing I can say just while we wait, was that in the interviews with contact tracers, they impressed upon me the breadth of their role. So when they first speak to a case, it's not just about who else this person has been in contact with. They did really important caring work about checking that a person was okay, checking that they had access to medicine and food, that they were actually going to be able to isolate. And so that's another reason for thinking that just simply bringing in digital contacts, a digital system that is decentralized, you would actually miss that element of it. And that, I think that caring element of it was really important. Again, that was something that I think was not able to be sustained when you've got a much, much bigger epidemic, as we've seen in recent months.
Yeah.
But I guess it's important to think about holistically about the work of contact tracers, which is also as part of a health care system, not just about infection, but also about caring for people so that they are, able to comply with the directions that they're being given.
Yeah, I think like in terms of like privacy, I think as Emily point out, like people use a lot of different social media, like all their information is available, and then like people use it for like different research. So maybe people are not aware of it. I don't know.
Look, it is a good point, and maybe we need to have a real national conversation about privacy and about where your data goes, and about how drawing particular lines about who you think can have your data, and if you're basically letting any number of big corporations that you have no say over the governance of access your data, but you're saying that the government can't access it for a very important health reason. There's an anomaly there that we do probably have to address.
Yeah, I'd love to do a study, and then we could even just ask people if they know what data is already available to people. Fascinating.
Yeah, I think that would be fascinating. Yeah, go ahead with that one. It's a great idea. There's a grant in it too.
Squeeze it in between all my spare time.
Yeah.
All right. I guess no more questions from the audience. All right, then and then let me thank on behalf of everyone for joining us today, and it's lovely to meet you, and then great talk. Okay,
thank you very much. It was a real pleasure to be here.
Yeah,
and the best of luck with the rain.
Yeah,
we're thinking of you.
Yeah, thank you.
Thank you very much. Goodbye.
Bye.